Yeah, we are live.
Good evening, everyone. I welcome you all on behalf of Team YOSI and YOSI Legal Core team to this wonderful evening. So we started this webinar series with the intention of educating the young ophthalmologists regarding the medico-legal aspects in ophthalmology. And the topics covered so far include consent, Consumer Protection Act, record keeping, indemnity insurance, how to respond to a legal notice, medico-legal issues regarding cluster TAS and cluster endophthalmitis, telemedicine and its medico-legal aspects, cataract surgery and related medico-legal aspects, retinopathy of prematurity and its medico-legal aspects, issuing medical certificates, intravitreal anti-VEGF and its medico-legal aspects, billing related medico-legal aspects in ophthalmology, medico-legal issues related to mass cataract surgeries, medico-legal aspects related to refractive surgeries, NMC guidelines for ophthalmologists, and our last session was on tackling assaults against doctors, its medico-legal issues. And I am proud to say today we are having our 17th session where we are going to talk about medico-legal aspects related to live surgeries. So it's always an honor to introduce our panelists, and we are grateful to them for their wonderful guidance. We have with us Dr. Anant Deshpande sir, who is director and eye surgeon at Guru Prasad Netra Rugnalaya at Aurangabad. He is chairman of Indian Medico-Legal Consulting Services Private Limited. He is co-chairman of Legal Committee AIOS. He is faculty of law and visiting professor to Symbiosis Law College in Pune. He is National Law University Aurangabad faculty. He has written various books like Legal Aspects in Ophthalmology, to name a few. Thank you so much, sir, for being with us. Next, we have with us Dr. Prakash Marathe, sir, who is consultant ophthalmologist at Netra Yogi Eye Clinic in Pune. He is past president of Maharashtra Ophthalmological Society, Pune Ophthalmological Society, and Indian Medical Association, Pune. He is member, Legal Affair and Expert Group Committee of AIOS. He is chairman of Maharashtra chapter of ISMS-ICS. He is past Managing Committee member of AIOS. He is past Senior VP of IMA Maharashtra State. He is Honorary Secretary, Social Security Scheme, IMA Maharashtra State. He's won various awards, to name a few: President's Appreciation Award in the year 2018 and 2022. President's Appreciation Award by IMA Maharashtra State for the year 2013, 14, 18, 2020 and 2021. President's Special Felicitation Award by IMA Maharashtra State for the year 2021, and POS Late Dr. Asha Kelkar Award 2022 by Pune Ophthalmological Society. Thank you, Marathe sir, for being with us.
Thank you so much.
Next, we have with us Dr. Manoj Chandra Mathur sir. He's senior consultant in glaucoma and comprehensive ophthalmology at Swaroop Eye Center in Hyderabad. Presently, he is the honorary treasurer of AIOS. He's past advisor and president of Telangana Ophthalmological Society and Hyderabad Ophthalmologist Association. He's co-chair of Health Insurance and TPA Committee of AIOS. He has been a member of Medical Legal and Ethics Committees of AIOS in past. He has been twice member of Managing Committee of AIOS. He has also served as a member of Advisory Board of IJO. Thank you, Manoj sir, for being with us. Over to you, Dr. Kaushik.
Yes, we are privileged to have Namrata ma'am as our speaker today. Ma'am needs no introduction. She has been a has been a teacher and inspiration to many of us, including me. She is professor in ophthalmology in unit of cornea, cataract and refractive services at Dr. RP Center, AIMS, New Delhi. She did her post-graduation from the same institute. She did her fellowship from Moorfields, UK, and she is the regional secretary of APAO, and she is the honorary general secretary of AIOS. And ma'am has multiple awards and patents to her name. She is the brand ambassador for TFOS in India. She is research committee member of APAO. She has won multiple awards, and she is one of the 1,000 Indian scientists in the list of top 2% scientists in the world by Stanford University. He has been named as top 100 most influential ophthalmologists 2022 by APJO, and she got APAO Senior Achievement Award by the APAO. She is holding multiple positions, and she has been an inspiration to many of us. She is president Cornell Society of India. She is Vice President of I Banking Association of India. She is Vice President of NSPB, Regional Secretary of APAO. She is the General Secretary of Ophthalmic Research Association, which conducts academic activities of RP Center and conferences. She is also Chairperson Scientific Committee of ISC KRS, and she is the Chairperson of ARC Dr. RP Center AIMS. Thank you, ma'am, for sparing your valuable time. And over to you, ma'am. Thank you.
Thank you. I think I would like to thank Young Ophthalmological Society of India for holding so many important webinars or important sessions on medical legal issues. I think that is something which is neglected, and that is something which is beyond ophthalmology. I would also like to thank them for having me today to talk on a subject which I am truly passionate about. Should I start, Kaushik?
Yes, ma'am, you can share your
Yes,
screen.
ma'am.
And in front of the august panelists, again, it is a pleasure and honor to be presenting. I'm sure things are going to be discussed in a manner so that it will be beneficial to all. I know people may have strong opinions about live surgery, whether they want to have it or they don't want to have it. And we can always discuss it threadbare. So I think you can stop me at any point that you want to, and we can always discuss it. Uh, what are the pros and cons of live surgery in ophthalmology conferences? I wouldn't say in ophthalmology conferences, because we know that it is done quite a lot in other conferences. For instance, if you ask me, and when we went through the literature, we found that it is maximally done in urology conferences. Apart from that, I know and I have been a witness to cardiology. They do India Live, which is again the transmission of the live cases from all over the world. And that's a 3-day conference. In many of the state conferences of ophthalmology, we hold it. But apart from this, gynae, gastroenterology, and so many other specialties and fields are the ones who are doing live surgery for the purpose of education and teaching. So if you review the literature, or if you see the PubMed, it will not come as live surgery, but they call it as LSB, that is called as live surgical broadcasts, which are actually real-time transmission of surgical procedure from operating room to remote audience through various media channels, which could be TV, internet streaming, or video conferencing channels. And it primarily, the aim is that it serves as educational training, and it is for information purposes. It provides opportunity for medical professionals and students to witness the surgical techniques, learn from the experienced surgeons, and stay updated on the latest advancement in medical procedures. We as surgeons know very well that when we do surgeries and when we actually present surgeries in conferences, there is a sea difference between the two. What we actually do may be spanning for 2.5 hours, and what actually when we demonstrate in short presentations or even longer presentations are the edited versions of actually what we are doing. Of course, we can edit the whole surgery to show the good things in it, or we can edit the whole surgery to show problems which occur during the surgery and solutions which were thereof. So it can work both ways. Some surgeons like to show their best of the things and not like to show their complications. Others are bold and will show you the complications and will also show you the methods by which those complications can be solved. I think the live surgical broadcasts have picked up more recently in the recent times because earlier, probably people just flocked to conferences, but now you have so many channels. You have YouTube, you have Facebook, and you have other channels, Vimeo channels, etc., where these can be broadcasted. Now, important thing is that tells you about real-time learning. Sometimes what happens is that you may edit the steps which people may be facing, and when actually life surgeries are held, what many delegates or many people who are attending have felt that even when an experienced surgeon is doing a live surgery and facing problems. So for instance, if they're demonstrating a phacoemulsification surgery and if they have an iris prolapse, or if their capsular excess is small, or if they have other problems, for instance, when you're doing a DMEC graft, there are so many problems which can occur. So when actually the delegates see it, they know and they can identify with it, and also know that even the experienced hands can have these kind of things, and also learn simple ways and techniques and maneuvers to actually overcome those. So that way it gives you a real-time learning, because it is an opportunity to witness the entire procedure firsthand, and also the complex procedures firsthand. There is interactive education because the attendees who are there can ask direct questions, seek clarifications, engage in discussions with the surgical team. Sometimes the surgeon may not want to answer all the questions, then the people from the surgical team can answer those questions because you are engaged in surgery. And it gives you more interactive and a dynamic educational environment. It is not possible for everybody to visit centers of experienced surgeons. So when they get to see those at a place which is common, or even on a digital platform or virtually, then without actually having to visit the center of an experienced surgeon, or a surgeon who's skilled in a particular skill, and you want to learn it, you can actually gain experience. And sometimes it offers you only a stimulus to do things which you may think are difficult to do, but you see them in live surgeries, where you get stimulated and inspired to do it on your own. It does help in skill enhancements because, like I said, the trainees, or even why trainees, even people who want to refresh, even senior people who want to reorient themselves or refresh their steps of surgery can do so by looking at live surgery, because every surgeon has a different way of doing things. And sometimes very small tips and tricks, or very small things which are actually not written in a book, and which you read 3,000 pages of a book, you may not know, but somebody just tells you that small tip or trick by the way of demonstration, and by actually doing it, you instantly would pick it up. There is an expert commentary, and like I said, that can vary. The surgeon is comfortable, he can give the commentary. If he's not comfortable, he can depute somebody else to do the commentary part. And there is one-to-one transfer of skill in live surgeries. Now, it does help you also to do networking, and also fosters collaboration among the surgeons who actually go and do live surgeries at a particular center, where they may do networking with each other. One can demonstrate new technologies, one can also demonstrate old technologies, but a new way of doing it. Then it has broader connotations, in the sense that audience has access to, like I said, not only national surgeons of repute, but also internationally sometimes, and has a global reach, and vice versa. The surgeons also are able to demonstrate their skills to, or they can teach their skills to a wider audience, which could not only be at the national level, but also internationally. So hence it helps to foster, promote in mutual exchange of the knowledge, which means the dissemination of best practices, standard procedures, evidence-based techniques, promote a higher level of consistency and quality in surgical approaches, and also not only tell you what to do, but what not to do. When you do see your role models or experienced surgeons operating, then it does inspire you and motivate the young medical professionals to actually learn from these experienced surgeons, and it encourages a culture of continuous learning and improvement in the medical community. And of course, it does help in professional development. It does help you to gain recognition and contribute to the advancement of the field. Now, there may be flip side to it, but I think if you follow all the rules and regulations, take proper patient consent, tell the patient that he is going to be a part of the live surgery, and take a written consent in his own language to say that the privacy concerns may be there. And the patient knows about all these things. I think there is nothing wrong with it, but then that may be there. And in all life surgeries that we do, the consent is taken. And when the patient doesn't consent to it, then obviously those patients are not taken up for life surgery. Then ethical considerations are something which have to be adhered to, and informed consent is required. Ensuring the patient anonymity and maintaining the highest standards of patient care. I think that is most important, especially in terms of quality control, and especially in terms of taking all precautions that all the surgeries or surgical procedures are done safely. And these are the concerns which do require a careful attention, and one has to be especially careful during a live surgery. Now, there can be technical challenges also while doing live surgery, because there may be problems which may be related to the connectivity, because most of it is done through the internet. Then there can be equipment malfunctions. Then there can be poor video quality, which can actually disrupt the way the surgery is getting transmitted. And also, one may not be able to have a complete kind of interactivity, because that would also depend on the surgeon who's demonstrating it. There may not be one-to-one interaction, but interaction with another colleague who's actually transmitting the information. So that is a possibility. And I believe that even when we are teaching postgraduates, or we are teaching trainees or fellows in our own hospitals, for experienced surgeons, it is like a live surgery every day, because they sit in your, for instance, they are there, the postgraduates are there, they are assisting you. The trainees are there, the fellows are there, they are assisting you in surgeries day in and day out. And you are actually teaching them the steps when you are doing the surgery, and also teaching them the steps when they are doing the surgery. Because you're monitoring their surgeries. So it is like a live experience every day, especially in the teaching institutions, and that is the way to connect, and that is the way, in fact, to transfer the skill one-to-one. Now, like I said, informed consent has to be sought. All the regulatory approvals should be taken from the regulatory authorities. And I think the most important thing is that one has to follow up these patients really very carefully, and keep all the follow-up data on record. And there may be a risk of negative public perception also. Now, I think these we can discuss in detail about the informed consent, the privacy issues, and the ethical guidelines, because we do have a whole team of panelists who are well versed with this, and I'm sure we'll be more educated by the panelists who are sitting here and who would be telling us more in details about this. Now, like I said, one has to really prepare very well when we are doing live surgery, especially for the institute, or especially from the operation theater from where the live surgeries are going to be demonstrated. You do require rigorous testing of the equipment before the live sessions, and this includes the testing of your OT equipment, as well as the testing of the equipment which is going to transmit your surgery. And there should be backup plans for the technical failures. Like I said earlier, the enhanced consent protocols in the patient's own language is very important. You have to be transparent with the communication with the patients, and you have to incorporate a specific type of consent for this live broadcast. And post-op analysis, including follow-up sessions or case reviews, is again something which is very important. The patient may or may not follow up with you. Then in those cases, it is important that you co-manage these patients with the ophthalmologists with whom these patients are going to follow up. And so I believe it is a good method of live surgery presentations are good method of teaching and education. And one should not underscore the dynamic nature of the medical education and the professional development, which you can see so extensively, which is happening on the internet nowadays. And I think we have to move ahead with the times. I believe that it is it is a method of medical education, and if it is done under proper ethical considerations, proper consent, following proper guidelines, then it does help to transmit the skill from one to another, besides imparting medical education, and also besides actually transferring the skill from one to one. So I think this is now open for discussion, and we can discuss the pros and cons both of live surgery demonstrations. I must have moderated, I have forgotten the count of the live surgeries that I have moderated, especially in ophthalmology, but they may be almost close to 100 or maybe more than that. And to my mind, I feel that I have not, I mean, till date, and touch wood, I've not encountered any problem which has been really serious in terms for the patient or otherwise. And most of the surgeons who are actually on live surgical platforms are very experienced surgeons. So I feel, but having said this, proper precautions and due considerations of ethics and regulatory are something which are mandatory, and they should not be, one should not try to bypass those.
Thank you so much, ma'am, for covering the topic so really well. We'll take the opinion of our panelist. So we'll start with Anandesh Pandey, sir.
Sir, unmute yourself.
Sir, you are muted. Can you please unmute yourself?
Sir, unmute kar, yeah. Yes.
Thank you, Namrata, Dr. Namrata, for giving such a nice information of the LSB. And really, she has practically covered every part of that LSB. The only things that I have to add is only the things which are from the legal points of view. And that I will say that the surgeon side, whenever a surgeon is operating in his own operation theater with his regular patients and everything, he is not in tension. And there can be three types of this LSB. That first is in patient, doctors operating in his own operation theater with his own patient, or doctor is operating in somebody's operation theater, that is in conferences which is arranged. And another thing is that is YouTube, which is maybe the actually, or it may be modified and everything. So leaving about this apart, the surgeon side, the important thing is that that she has already mentioned that if the patient and surgeon is very senior and a good one, he cannot have tension, he cannot meet any emergencies or the complications because of the tensions and all that. She has practically covered everything. Only the thing I will suggest that if the surgeon is from outside the India and he is operating in the India, he should be registered with the NMC and he should have a temporary registration number, and then he has to operate in such circumstances. Another thing about the surgeon, if he is operating of the other patient rather than his own patient, he should go through whatever consents the patient has given to the organizers, and the particularly special consent of privacy. And secondly, for my broadcasting or for my information or teaching purposes should be given by the patient in separate pro forma and separate form, and should be signed in his own language, and thumb should be taken, because signs he may refuse afterwards. So all these precautions, if the surgeon takes, surgeon is safe. On patient side, everything goes, nothing happens. But if anything wrong goes, then the patient can go in the consumer courts. Fortunately, the new government has abolished the criminal liability of the all doctors arising from the medical profession. So that portion is totally now not with us, and so it doesn't require any discussion. Only the consumer. So he can go in the consumer court, and for that he should, the surgeon, the hospital, and if the organization is organizing, that is some ophthalmic conferences or some other conferences is organizing this life surgery, they should have a good indemnity insurance. If at all he goes and the case stands, they should be able to pay whatever the compensations he is demanding. Another thing is the hospital liability. If the own hospital is there of the surgeon, there is his own liability is always there. But if he is operating in some other hospital, whole liability goes to the hospital. So the hospital should have good all the permissions from the patient, consent from the patients, and also the indemnity. That the conferences subside, especially when we are conducting the live surgeries in the conference in somebody else's operation theater with some patients unknown to the surgeon. All these things, whole things goes on conference organizing body also, that is LOC. So LOC should have indemnity insurance, and LOC should see that the surgeon is registered if he is from abroad, and their proper consents are taken, specially consent for all the things which I have mentioned, that should be taken, and then the only that should be done. This is the best way of teaching. I agree with Dr. Namrata that actually teaching, showing the surgery to the students and people is the best way of transferring the skill and educating. But the thing is that the hazards which can happen, we have to take care of that. Then the liabilities and educational side, that liabilities I have mentioned. Educational side, Namrata has already explained very nicely. So that is the best media for the educational purposes. But follow-up should be done particularly by a qualified ophthalmologist, and that should be recorded, and if possible that should be communicated to the surgeon if he is not from that place, and his advice should be taken into consideration, and patient also should be told that the follow-up things are being told to your surgeon who has operated you. The thing is that patient should be clearly told that who is going to operate for this particular case, and then doesn't remain anything which requires, particularly the analysis which happens in the conferences, that when the surgery is going on, only what is going on should be broadcasted or discussed, and what the things goes which may affect the mental condition of the patient should not be discussed in front of the patient. When the patient is out from the OT, all the discussions, panelists and all that should start the discussion and questions and answers and everything. Otherwise, the patient may hear it, but the patient should not be able to hear what the discussion should be going on in the outside or in the operation theater. And so that should precaution, because that may affect the mental condition of the patient, and patient can go in tension, and he can say afterwards that because of their discussion I got disturbed. So all these things, if taken the precaution, this is the best source of education of surgery and complications and how to treat the complication also.
Thank you so much,
Yeah.
sir, for highlighting the medico-legal aspects of the life surgery. In continuation to your comments, sir, I have one question. You have a very vast experience when it comes to medico-legal aspects. So have you come across any case wherein a patient has filed up a case against the operating surgeon or the institute, like he got operated in the life surgery, and then
To my knowledge, it is not there.
Okay.
To my knowledge, maybe there, but up to my knowledge, it is not there.
Fine, sir. So we will move on to our next panelist, Dr. Prakash Marathe, sir, for your comments, sir.
Thank you, Dr. Aarti. I think I must congratulate YOSI for organizing this wonderful webinar on medical legal aspects. And today's topic is very, very important. And Dr. Namrata ma'am has covered this live surgery topic in fantastic manner. All the points are very well covered. And expert comments by our senior ophthalmologist and medical legal consultant, Dr. Anand Deshpande. I think he has covered almost each and everything. So the point about this live surgery in the past, I think in one of the conferences of abdominal surgery, probably as there was a complication, that thing started. Otherwise, it is a very good tool for students, newcomers, youngsters, and even seniors, what Namrata Madam has said. It is a good platform for each and everyone to learn because it is the practical demonstration. And how to tackle the complications is very important thing. Basically, when we talk about the surgeon operating in different atmosphere, different operation theater, the important thing is there are various types of surgeons. Basically, the surgeon may be very good, but he doesn't have that particular, I should say, courage or that confidence to demonstrate himself with that live surgery in that particular scenario. Those people are not ready to operate in live surgery. But the person who operates in live surgery session, I think he has that mindset to demonstrate his surgery. That's very important. And there are various surgeons, what we have observed, even in ophthalmology conferences, they are barely masters demonstrating their live surgery. And basic important thing is that whenever there is a complication and there are various steps and how those steps are tackled by that surgeon, that's very important. And what precautions are to be taken, all those things Dr. Deshpande sir has very well covered. Important aspect is that the foreign doctor, overseas doctor, when operates in India, I think NMC registration is must, that temporary registration. Other important thing is that when you take that medical indemnity insurance, probably in that insurance it is written that in which area you are practicing and at which places you are doing your surgery. Probably when you are going out of the state, whether the mention about that particular state in your policy is written or not, I think that is the separate point. What I'll ask Dr. Deshpande sir afterwards to answer about this. The person from Maharashtra when operates in Assam conference, and if it's not written in his policy, that is important thing, because even if it is a responsibility of the hospital and that conference center about that live surgery session, the surgeon also has got some vicarious liability, and that way he cannot escape from that responsibility. Other thing is that recently All India Ophthalmological Society has tackled that issue in a nice way. As a panelist, I must say that live surgery is the very good tool for all of us to learn. We must proceed. At Pune Ophthalmological Society recently, and even in few of the conferences, we have tried to we are trying to settle that issue of live surgery. Just the surgeon operates, and then after operating, within next few minutes, he is sitting outside the operation theater, and the whole video is displayed and it is seen by the delegates. At the same time, the surgeon is doing the commentary when he is not doing the surgery. It is deferred live surgery. That is one of the options to get rid of all those points what Dr. Deshpande sir and Namrata ma'am has said. Probably those complications and those problems could be avoided by that way. Another thing is like sponsorship in the conferences. What you get for live surgery, you may not get for demonstration of good videos. But then deferred live surgery, if you convince even the sponsors, even the delegates are satisfied, even the surgeon who is doing the live surgery is in very nice mindset and he can explain his surgery in a nice way. That is one of the options. And I think this is what about I could say about this particular live surgery. There are few experts like Dr. Mathur sir is also there. About that question, Dr. Anand Deshpande sir, one
Yeah,
surgeon who
please.
is from one state operating in other state, and in
Yeah.
his policy probably the place
Yeah.
where he operates is also mentioned. How to tackle that?
Yeah. The thing is that our all indemnity policies,
Hmm.
generally with the standard companies, if taken, they cover to the doctor. That surgeon is covered. So as a surgeon, he operates anywhere in any OT within the limits of India. He is covered. It is not that the state limits are there, but Indian limits are there. He cannot operate outside the India and get the indemnity insurance. That is there. But if one he is insured, it is insured for all the states of the India. So nothing, whether it is central government area or the state government area, it doesn't matter much.
Yes, they do take the address, the working area, but the next sentence states that this indemnity covers to all over India.
Yeah,
Yeah,
that
that's
is
very
true.
important.
In all
That is true.
indemnity.
Yes.
One thing I like to add here, like in one of the conferences, the expert surgeon outside India visited, and then he was not authorized to do the surgery officially, but he was there. He was witnessing the surgery done by someone else, and then he was doing the commentary. His expert comments were delivered, and those were conveyed to the delegates. I think that is also one of the options. If the overseas surgeon doesn't have that particular registration on that particular day, I think we can utilize his expertise for that particular surgery like that. Over to you, Dr.
Yes,
Arti.
yes.
Not
Not
required.
only not in front of the patient. That's all.
Yeah. So, Marathe sir, you have worked a lot when it comes to consents. So I understand that we have to inform the patient that you are going to be operated and the surgery will be shown live. So I just wanted to find out, do we have a standardized format for taking a special consent for live surgeries by AIOS?
Actually, we have worked for that consent booklet, and I have transferred as coordinator those consents in Marathi format. But about the consent for live surgery, there was those separate consent. But you can modify our routine consents, like what Dr. Deshpande sir has said, probably about his privacy, whatever he wants to disclose, he doesn't want to disclose. That is important thing. Another thing is who is the surgeon who is operating, what type of demonstration is being done, what is promised to him, and probably about some complications also it should be mentioned in the consent. Suppose some complication occurs, I think he should also be told about that. And about the live demonstration, the patient must be informed. He
No,
shouldn't
there is a clause in our booklet.
Hmm.
Whenever we are operating, and there is a clause.
Hmm.
If the your surgery will be made live demonstration, or it may be made as a educational purposes, and all that, that clause if included, which we have included in AIOS, has included that clause, that if as such the consent is taken, which the AIOS has formed, that it covers.
Sir, that
Only
paragraph,
one thing, yeah,
that paragraph is there, sir, but it is not
yeah,
for live surgery. See, suppose you have got the video
yeah.
about
That's I am going to say.
disclosure of the
Yeah,
identity of the
yeah,
patient, that is a different entity.
yeah.
But when the
That's why.
patient is getting operated in live surgery session,
Yeah,
I
yeah,
think,
and that is covering it.
okay,
When you are doing it live surgery in conferences or such places, you have to add that much.
yeah.
So maybe all the big bosses from AIOS are here. So maybe Namrata ma'am, we have a suggestion that we can design the special consent form for the live surgeries, and then that will be actually strengthen the point of doing live surgeries. So moving on to our third panelist, Dr. Manoj Mathur sir. Sir, we would like to hear your comments.
Yeah, a very wonderful exposition by Namrata and followed up with valuable medical legal inputs from Dr. Deshpande sir as well as Dr. Prakash Marathe sir. How I see the evolution of life surgeries way back in my early career when they used to operate in hotel rooms. So that was the time when there was an objection to the life surgeries. To the present day, when we have come to a state that the surgeon can operate from their own operation theaters on their own patients with the comfort of their own theaters is a long way. Like there's a vast difference where the argument is that the surgeon is not comfortable in a new place. The surgeon may not be comfortable with the attending the OT staff and whatever. But now with the current technology, there is an option for the surgeon to be operating from his own theater. The surgeons can operate from their own places all over the country, in fact, all over the world, and that surgery can be transmitted. So a lot of medical legal issues are taken care of if we adopt this formula. Then another question I would like to address, the difference between the live surgery, deferred live surgery, and unedited videos. So a live surgery may have certain cons, but deferred live surgery, as Dr. Marathe said, like it doesn't make much sense. Like a surgeon has just operated and now he's sitting outside the OT and commenting on his own live surgery. Better than that is the live unedited surgical videos where the surgeon himself can be among the audience, stand on the podium, show his surgery, and then discuss. The important factor that we need to know the difference between an unedited video presentation and a live surgery is the wow factor. We sitting as delegates in the audience, we are sure we know the outcome of a live unedited video. Suppose if the surgeon shows some complication, we are sure that the surgeon is going to show a good end result. That's why he's standing in front of us and presenting. Whereas in a live surgery, that element of suspense is there. The delegates, the audience, they will be keenly observing the fact as to how the surgeon is proceeding. And that wow factor is there in live surgeries that is not available in live unedited surgical videos.
That's true.
Deferred live surgeries, I think, has no particular role. If we plan live surgery cases in a conference setup, I suggest the way forward for all the organizations is that better to avoid local live surgeries, better to transmit live surgeries from different operation theaters by reputed the surgeons on their own patients, and then there is no problem with the follow-up of those patients because that particular surgeon will be following up the cases, and then so many legal issues can be taken care of, and the delegates do get the advantage of the live wow factor in the surgical cases.
Now, again, advances are there, 3D. And you can go now for advanced that 3D microscopes and everything. And if that is projected or being shown in the conferences, actually feel is there that you are in the operation theater and looking. And that feel gives a better educational quality and better education, definitely. So the way we are proceeding on that side also, today or tomorrow, we will achieve that also, I think. And AIOS is there to support we people.
Mathur sir, I have got a question. What you
Yeah.
said that the surgeon is operating from his operation theater. Like suppose at the time of a big conference, those surgeons are also supposed to attend the conference. So the very next moment, probably they will be traveling and coming to the conference. So they will not be available at their premises for follow-up of the patient.
Now with the current connectivity, their commitments can be scheduled. They're like they can be generally the surgery day, the live surgeries happen on a pre-conference day or the first day of the conference. Their
Pre-conference day.
commitments can be scheduled for the next day, and they can certainly fly down to the conference venue for the next day. That can be easily arranged. How many surgeries? We are showing 10 surgeries, 15 surgeries, 20 surgeries, 10 surgeons operating
in
a delegate strength of about 5,000. 10 people can fly overnight and come over to the conference.
How will you take care about the sponsorship of the conference in that case?
Yeah, sponsors, there should not be a sponsorship issue because the surgeons operating, the sponsors are always there. They will be sponsoring a particular, they will be preferring a surgeon where that particular surgeon is using their equipment, and the company should not have any problem sponsoring that particular surgery on their own equipment. They can show their equipment. The scientific committee can select a particular surgeon. Like suppose a particular company has 10 units in the country, the scientific committee has well within its right to select a particular surgeon. We use of those 10 surgeons, one surgeon using that particular equipment. The sponsorship company should not have any issue because their equipment is being used.
I think your option is very good in today's scenario where the platform like Zoom or these audiovisual transmissions are possible. Because in the past, what we used to do in live surgery, probably the surgical OT was connected with the conference hall with various cables, and that was very difficult and costly
they
also.
used to pull a cable,
Now, because of
1 kilometer, 2 kilometer long cable. That is no longer there. You have a Zoom platform right away.
Now it's changed.
Namrata ma'am, you also have got
head over his change. And what the problem we face basically in our society is when we had these resolutions not to go for live surgeries were outdated. That time, the people, all of us who supported the ban on live surgeries are now opting for live surgeries. So that is the case. Why? Because of this drastic change, this change of scenario. We are having confident surgeons. There's no dearth of good surgeons willing to operate live from the comfort of their theaters, from the comfort of whatever. Like that is the way to go. And especially with the proliferating events that are happening every weekend, there is a conference at the city level, state level, and the national level. There are so many events going along. So there has to be there's a lot of opportunities, and this problem should not be seen at all. And with a good connectivity, as Dr. Marathe said, the surgeon can operate in the morning, fly down to the conference venue in the evening. That's not at all an issue. And now basically they say, I want to know what is the difference between an unedited live surgery video with a surgeon standing on the podium and explaining his video and the live surgery.
He has
This
got
is
a
the thing,
choice.
as I said, this is the wow factor. The delegates are in suspense as to how the surgeon is going to manage. Whereas if it is a live surgical video, then the audience knows that the end result is going to be this.
That is unedited video. Probably the surgeon has got a choice whether to demonstrate it or not.
That
In
is,
live
and we
surgery,
cannot understand whether it is edited or not.
and whether it is the same video or not. There are various
Yeah.
options available. So real life surgery is real life surgery.
So we will, I just want to pitch in some,
I think I would request Dr. Kaushik Tripathi to talk on it, because he may not be saying the things, we are saying, because I know he has different views on life.
The concerns are that if what Manoj sir said, if the surgeon operates from its own convenience, from in his own patients and in his own center, then the most of the challenges are overcome. But this thing, like patients' benefit, should be our topmost priority everywhere, whenever we are treating or whenever we are operating. And their experienced surgeons may not feel it, but definitely there might be an increased stress level in the surgeon who is operating in a different center, different setup. Maybe the same machine, but it is staffs are different. So uh, is there an increased chance of risk to the patient when a surgeon is operating? That is the challenge there in live surgery, and that is what we'll have to like. Yes, sir.
Yeah, I want to quote certain instances way back, where I think about 40 years back in Hyderabad itself, there was an incident. Like, the over-enthusiasm of the anesthetist, the over-enthusiasm of the surgeon is always cited as a reason why live surgery should not be performed. Here in this instance, what happened was the patient had the G6PD deficiency, and the patient had an arrest, cardiac arrest, because of anesthesia. The patient was revived. After some time, over enthusiasm of the patient, the surgeon wanted to operate, do something. The anesthetist was willing to repeat the anesthesia, and the patient died.
No,
Then
that is a I think that is
yeah,
a
so that is an over
That should
enthusiasm
not,
and
that should
the
not be
pressure,
done.
the pressure to do the surgery, the pressure to do the surgery.
That
What I
should not
mean to say,
happen even
that
in normal
should not
Surgeons
happen.
should understand what are the limits.
even in
I-
normal
that is
circumstances.
the thing.
That should
That
not
is
happen.
one instance. And the second instance is the instance that is widely quoted. The surgeon, over enthusiasm of the surgeon to persist with the laparotomy procedure rather than to open it up and do the things, because it's the like the prestige of the surgeon. Those things do come up, especially in the live surgery scenarios, but these things should be taken care of, and the clear-cut guideline should be there for surgeons as well as the patients. A proper consent. The patient is aware that the surgery is going to be live streamed. The patient is aware that his or her name is not going to be, so his privacy is going to be maintained. Only the operating part is to be telecast. The patient gets a benefit of getting the surgery done by a reputed surgeon. If you just spread the word among the local community that particular stalwart surgeon is going to come and operate, you just specify the procedure, there will be at least 10 patients willing to get operated. So that thing is there, but provided like at every step proper guidelines are followed. In such cases, like if the surgeon is operating in a new place, a proper like recce of the theater should be done, and then the doctor should be authorized to do a proper follow-up, and then they should be in contact with the operating surgeon, and the operating surgeon's note can be taken up on teleophthalmology. The image can be sent to the operating surgeon. All those things are possible, like a proper follow-up, proper consent, proper technique, everything can be done. And why this thing is come now, especially in AIOS, is like we have started a midterm conferences. What didactics, what same symposium, what same thing. We have to have something new to be infused with this, and with that intention only, the iOS governing body thought the benefits of live surgery, and that was the main reason why we thought we must give something new to the delegates, especially in the midterm conferences, apart from the routine didactics. That was the intention. All precautions were taken and everything passed off very well.
So those kind of things, when surgeons insist to cross their boundaries, that should
Yes.
not happen
Should
even
not have
normally.
happened.
Not happen even normally. I mean, normally also when you're not doing a live demonstration, you should not do it. I mean, so I think that would
In
entirely
that situation, the surgery would have been definitely postponed.
no,
But
no,
here,
Definitely.
the pressure of doing the surgery was there.
that pressure.
That's why
No,
it was
why
I
necessary.
pressure,
think
sir? Another patient he can take
I
instead of
think
that.
ethically we should not succumb to this under any circumstances, whether live or
Yes.
not live.
That's what a professional guidelines have to be
Yeah.
followed
All
very meticulously.
So that is, I think, the surgeon's own attitude, and that is something which needs to be corrected at the
Yes.
DNA level rather than anything else. And
Yes,
that
yes.
should not be done even otherwise. So those etiquettes, those professional etiquettes, I think everybody should have, whether live or not live.
Also, the mitigation strategies, if there are like complications, how, like, who will take care of the patient, and how, what are the standard operating procedures to mitigate if there is any problem, any complication, or endophthalmitis or something bad if it happens. There should be clear guidelines or clear explanation to the patient before like operation.
You have, Kaushik, so many times people operate, your own fellow colleagues operate, and they refer cases of endophthalmitis to you. So you do take care of that also. And those situations of infections, etc., are not something that you're wanting to happen, but they do happen. So they can happen even in this situation, other situations also. And I think those should be managed the way you would otherwise also. I'm sure Dr. Deshpande sir will tell us, how to do it in these kind of special situations. But having said this, I mean, it is similar to what, situation is otherwise also, live or not live.
In such a situation, the operating surgeon, if required, should come over, fly down again to the venue, see the patient at least once, along with the follow-up team, if required.
Yes, he should preoperatively should see, judge, and take all the precautions that his regular patient he is taking. And
And
even
he is
if the infection
responsible for the
happen or
post-op
something
complications
happens,
also.
it should be as if a regular patient is there.
So
So
responsibility
I
of
have
that.
one different question. So we are in the era where artificial intelligence and robotic surgeries are being discussed a lot. So I would like to ask our speaker and the panelist, do we have any clarity on how the medical legal aspects are going to be when it comes to a robotic, let's say robotic cataract surgery? Anand sir, would you like to comment something on
Yeah,
this?
robotic. There are no special laws are prepared at present. But for telemedicine, there are laws, ethics, and rules. And those all telemedicine law, rules, and ethics are for robotic surgeries. Because robotic surgery is as good as a telemedicine. Because the surgeon may be there sitting in the same room, or he may be sitting somewhere else and giving the directions to the robos. A robo is nothing but like a machine as we do on FECO machine. So many sensors are there, so many things are there. And if we operate that machine from a distant place, it is the same if we operate personally on touch. But the law which controls that is also controlling the telemedicine. And they at present, no special law is there for robotic at present in India, at least, either, to my knowledge. Maybe yeah, beyond that, it may be there, but as far as I know, there is no special law. But for telemedicine, there are so many laws, ethics, rules, and regulations which are controlling everything.
And these
Yes.
laws are not different from the
Yeah, robotic. Yeah,
convention laws.
yeah,
The surgeon is accountable the same way as this
yeah.
thing. And one thing I would like to have a clarification, Dr. Deshpande or Dr. Marathi or even Namrata can answer. Like, what is this robotic surgery? Is main surgeon, expert surgeon may be remote, but does it mean that there is nobody to attend on the patient locally? I think there has to be a surgeon
Yeah, yeah, yeah,
present there, and the
yeah,
robo is doing the thing. In case a manual intervention is required, that local surgeon has to intervene.
Yeah, that's true.
It's
That's
Yeah,
not
because
totally a
yeah,
remote
yeah,
surgeon doing the whole thing.
yeah, yeah. Communication may fail and the patient may be on the table. In such circumstances, it is
yes.
must.
In
Yes.
ophthalmology, we really don't have that way a robotic surgery. I do ophthalmology as of now we have, robotic surgery, although people will call femtosecond laser cataract surgery a robotic surgery, but that is not a robotic
Yes.
surgery in true sense.
Yeah, people are talking about that, what ma'am has said, as robotic surgery, femtosecond. And
So
even laser, yeah.
recently in the Sinmal meet, there was a session on robotic surgeries. There was a debate on robotic surgeries when it comes to cataract surgery, and I was talking for it. So I went through a lot of papers and research, and I got to know there are three companies, and it is being used in some of the countries like US, UK, and Netherlands. And they've highlighted the importance of doing robotic surgeries in VR surgeries as well, because the ILM is so thin and the surgeon might not actually know how much force to put on the ILM so that it doesn't tear. So the robotic surgery will help doing that in a better way. And there was a very interesting paper which I will share with you all. Dr. Kaushik, do we have any more questions?
No, we do not have anything in the chat box.
I think something else, we are talking about artificial intelligence. I think no much
Yeah.
more theories available, but then probably that is going to be the future.
I will like to speak about little bit of the robotic surgery, what Dr. Arati has said. The robotic surgeries are useful where actually your microscopes or eyes are not able to see. And if the robot finger or the tip or whatever he puts inside gives a good visuality to the surgeon, and accordingly he operates or gives the orders or to the sensors and do it. So in that circumstances, really it is useful. But in ophthalmology, there is no place where the doctor or the microscope doesn't reach. Maybe in future in some neural surgery or nerve surgeries or in orbit may be required in particularly orbital surgeries and all that. But at present, the routine surgeries, there is no role for the robotic at present, what you have seen. About the artificial intelligence is too much. And whatever you feed to the intelligence to the uh, program, the program works accordingly that really speaking, I don't know, you must have seen or felt it. I have felt a place where in school they were teaching with ChatGPT headphones. And when I was called there for giving the visit, and I gone. The professor said that the teacher said, "Sir, I will make you how it likes feels, how we teach." And he put the headphone on my head, and he said that this is a jungle, and I saw the jungle. Actually, I was in the jungle, and the man was coming, running to me, and immediately he said, "Now you are entering in the man," and I entered in man, and I was near to his heart, and I was seeing his heart, and I was feeling that I can touch his heart. And he just moved and he said that you are in the heart. And I was in the right uh, ventricle, and the blood was fully dying, going on me, and the walls were opening and going out, and everything was happening. And I was feeling that's really the blood is going on me. So that feel really is there, and they are teaching like they take the students to the jungle, and the lion comes, and they don't think that this is lion, that is lion. How it looks, he touched he touched, they are having. So they have a great feeling. So this feeling met, that is a meta world. When will come, everything will change in our field also, and it is now changing, and there is the place of artificial intelligence too much. How you feed that artificial intelligent person or the equipment, that will work nicely, and it has a tremendous use in future.
As of now, it is only misnomers in ophthalmology, like phacoemulsification was known as laser surgery. So now femtolaser is being known
Yeah,
as
yeah.
robotic
Laser
surgery.
is,
Oh,
yeah.
robotic surgery and
Yeah.
Now, in telemedicine, you can do the laser when sitting in the Hyderabad and your van is in a remote place. Very nicely, you can do it.
I think we have reached the end of the session. Namrata ma'am, do you want to give any comment before I give vote of thanks?
No, I think so many points were brought about by the panelists and the experts. Some of them even I didn't know. So thank you for doing this. And I'm sure we can come out with guidelines from the AIOS in a formal manner for life surgeries with the help of the same experts, same three experts that you have invited today, and both Aarti and Kaushik also can be a part of it. So that would be a useful resource for everybody who does live surgeries or wants to do live surgeries. I'm sure NMC will also come out with the guidelines of live surgery, and that will be helpful not only to ophthalmology but to all the surgical disciplines. Uh, I know that how much ever we may say, but because the whole world is doing it, so we all would want to do it. But I think we should refrain from few things like we should refrain from few things which are detrimental to it and follow proper guidelines, take proper precautions, just like you would in any surgery that you do as a surgeon. Have professional etiquettes, do it ethically. And I think we did not discuss something which was a little more important. That was the issue of sponsorship, which is always linked to it. So I think if we de-link that and if we try to, I know that we cannot do away because technology will keep changing and technology does drive science, whether we like it or not. And technology is driven by commerce, whether we like it or not. Having said this, if we do not go hand in hand with technology, then we are the ones who are, would be behind. But technology should not be the only guiding force because after all, we all have to think what is correct and what is not. Technology will come and go, but we are the judges to see whether it is really appropriate for our patients or not, who have actually so much of faith in us that, most of them would abide by what we tell them is best for them. So I think that is something which we should adhere to. And like I said, live surgical demonstrations are done with sponsors, but are also done without sponsors. Even the surgeries where we do not have anybody, but we want people to learn, even those are demonstrated. And so maintaining the ethics and the professional etiquettes, if you do it, I think there's nothing really wrong with it. But like I said, today's webinar is really, really very useful because you've got the right people on the right platform. And so many things even I have learned today. If we have, I mean, we can put all these things together in a script, and I'm sure it will benefit everybody.
To complement
Thank you
it,
so much.
I will say that right person to speak, give the speech was there.
No,
And so the session was very successful.
thank you so much.
that's true. That's
Aarti,
true. That's
before
true.
you do the vote of thanks, I would like to give one
Yes, sir.
comment on
Yes, sir. I was
sponsor.
about to call your name. I saw you raise the hand.
Yeah.
Over to you,
So,
Mathur, sir.
yeah, because Namrata raised the issue of sponsorship. How I take this issue of sponsorship is when you are giving a trade area space to a sponsor company to showcase their product. Here is something like theory and practical. A sponsorship for a life surgery is nothing but a practical demonstration of their product. What's wrong with that? So they say like you should not take sponsorships, but we see when you are giving them a stall to showcase their product in a passive way. What's the problem when they are able to showcase their product in a live way? There should not be an hassle at all in soliciting sponsorships for live surgeries. That's what I wanted to say.
Agreed to that, sir. So,
NMC has gone back for 2012 for their ethics. So now we are free to take the sponsorships. That was only curved when it was NMC norms of 2023. That has
Those,
gone. And
yeah,
I
no,
think they will never come back.
those norms are only for individuals, sir, not for
Yeah.
organizations,
Yeah,
and not
organizations
for
also.
conferences,
Everybody.
not for
Yeah.
surgeries. Yeah.
Uh, conferences it was there, and so that has taken away. That's okay.
So I would like to thank Namrata Sharma ma'am for sparing the evening with us in her busy schedule. I would really like to thank our panelists, Dr. Anandesh Pandey sir, Dr. Prakash Marathe sir, and Dr. Manoj Mathur sir, for being with us for all the 17 sessions. And we have learned so much from you all. And we look forward to continue this journey with three of you. I would like to thank Dr. Kaushik for moderating this session with me, and I would like to thank Dipanshu for doing the background work. He's little unwell today, so he did not unmute himself. And last but not the least, I would like to thank Team YOSI for giving us this opportunity. So soon we'll
Fantastic.
be announcing our 18th session. So be with us. Thank you, everyone.
Thank
and
you. Thank you very much.
Thank you.
Wonderful webinar. Good night.
Wonderful,
Thank you
wonderful.
everyone.
for doing this, for inviting, and for thinking about this. Thank you.
thank you so
Special
much,
thanks to
ma'am. And
Dr. Namrata.
You are the star speaker, ma'am, today.
You
She was
are
fortunate, and we were
experts.
fortunate to have you here.
Experts are, we have the best of the experts. I was a little nervous, if you ask me, in front of Dr. Deshpande, Dr. Prakash Marathe,
No,
and
practically, I suggested your name to Aarti.
Okay,
yes,
okay.
I was
Thank
about to say that Anandesh Pandey sir always picks the right person for the particular topic. And I called him up and I said, sir, can you please suggest the speaker? We thought of talking on this topic, and within a minute of like phone call, we finalized that yeah, Namrata ma'am will be the best speaker for this.
Yeah, perfect. She has got the experience of AIOS as General Secretary and Chairman Scientific Committee. She has operated in various conferences as surgeon and then moderated also. So the perfect person in perfect scenario, perfect position.
Thank you. And has been through the controversy of AIOS live surgery.
I know, I know.
I know.
But we have restricted ourselves to discuss and not to discuss few things here, and that's good.
Thank you.
This is not the platform.
Thank you so much. Thank you.
Thank you so much. And I'm sure Dr. Kaushik and me will work on what ma'am said, guidelines for life
I
surgeries
think
with
we should formulate for everybody. Okay.
the guidance of the seniors.
Because
Yeah.
if you
Thank you.
look at the literature, there's nothing much about it given anywhere.
Yeah,
And
that's true.
points which Dr. Deshpande sir told us and examples which Dr. Manoj Mathur quoted are not there anywhere.
Yes, ma'am.
Okay, thank you.
Thank you so
Okay,
much. Good
okay.
night, everyone.
Good night, everybody. Good night.